Welcome to Scrubbed In, Narratives from the Front Lines, a podcast from the University of Tennessee Health Science Center College of Medicine, created in partnership with the Teaching and Learning Center. This is a space for reflection and storytelling, where medical students, residents, and faculty share the real moments that shape the journey of becoming healthcare professionals. Also, please take a moment to follow or subscribe and share this podcast with a friend, colleague, or fellow student. Our goal with each episode is to explore the challenges, triumphs, and unexpected lessons that come with learning to care for patients and remind us that medicine is as human as it is clinical. So whether you're a fellow student, a seasoned clinician, or simply curious about the human side of medicine, we invite you to listen, connect, reflect, and scrub in. Let's move to the front lines.
Thank you all so much for joining us for the first episode of Scrubbed In. I'm your host, Dr. Anna Breland, a MedPeds first year.
And I am Dr. Chidinma Ukadike. I am a fourth-year MedPeds resident, and I'm excited to welcome Dr. Brian Porter, another fourth-year MedPeds resident here, as our narrator for today.
Hi, thanks for having me. Excited to be reading some of these stories.
Before we begin, let's hear a little introduction from our Assistant Dean of Clinical Skills and Training and Executive Producer of the podcast, Dr. Faria Abdullah. The good physician treats the disease. The great physician treats the patient who has the disease, said Sir William Osler. His teaching stayed close to the basics. Listen with intention, watch carefully, and let the patient show you what matters. I want you to think what you're really learning from this podcast. You're learning the human side of medicine, how to take a meaningful history, how to examine someone with respect, and how to see your patient as a person with stories and expectations. These skills are your entry point into understanding another human being. Every patient carries clues to their illness, whether they're words or in their body. Your role is to open that story with thoughtful questions and to let the body speak through what you see and what you feel with your hands. You're at the beginning of your training. You haven't had your own patients yet. You're still at the starting line. This can kind of feel a slow stage. It feels like you're practicing the same moves again and again, but there's real value in this. The way you sit, the way you listen, the way you pay attention. These are small choices that create trust and care long before you recognize it's happening. The stories you'll hear today are real. They came from students ahead of you, from residents, and from faculty. Moments where one question shifted the course of a whole case. Moments where the physical exam brought the answer into focus. Moments where presence and connection carried as much weight as knowledge. As you listen, picture yourself in these situations. Notice what stands out to you. Let these stories give you a sense of what you want to show up for in your own patients. This is your foundation, and you're building it one piece at a time. We've got some impactful stories for you from medical students and patients to share today about the importance of intentionality in the practice of medicine. To respect the patient's privacy, names, and identifying details have been changed while keeping the stories true to the experience.
What does intentionality look like in medicine?
I think intentionality is one of those intangible factors that often make some of the best doctors, the best. Whether it's taking an extra 10 seconds to ask a patient for the correct pronunciation of their name or creating a systematic process for evaluating a patient when you're so exhausted, being intentional can make many different forms. But the uniting principle of all of them is being in the moment.
That's a great way to define intentionality. From what I've observed, oftentimes as a physician, we're in such a rush to get everything done with so many responsibilities and so little time that we forget what it's like to actually be in patients' shoes. And we've all been a patient at some point of our lives.
Which is why it's so important to remind ourselves of what being a patient feels like and to get that patient perspective back. I'm excited to share a particular story of a patient's experience in a clinical setting as they battled through chronic illness. It really highlights the importance of being intentional in our interactions and what happens when we aren't. The smallest of details can make the greatest of impacts. So let's dive in with our first story on a patient's experience in a medical setting. You sit in another waiting room, another doctor at yet another clinic. You've lost count of how many times you've done this frustrating dance. The online registration, the wait while your body slowly decomposes day by day, the forms that never seem to get read by the people who need to read them, the endless repeated questions until your story is reduced down to that of a life paused by illness, to a single line. I am sick and I need help. You've been assured that this one is different, but how many times have you heard that? They're used to seeing people like you. They deal with that sort of thing all the time. I've heard so-and-so is fantastic with their patients. You should really give them a chance. All variations on partial truths, all ending in variations on insults you've come to expect. You submit yourself to becoming another statistic and hope you can make it through your visit with dignity intact. The receptionist calls you up. The name they call is wrong, an artifact of a life discarded. You haven't used that name in years, and you wonder why they even have it on file. You certainly recall registering under your real name. A shame your documents and chart do not reflect the change. You entertain correcting them, but slowly swallow your pride. Another battle for another day, another indignity you are forced to swallow for your participation in a system that was not built with you in mind. You are whisked back to the intake room, offering pleasant conversation to the one taking your vitals. This kind-hearted person calls you the wrong things, but that is expected. The old you still exists in their chart, thus must be correct. You could correct them, set their record straight, but is it worth the time? You are not here for that. You are sick, even as the cuff inflates around your arm and the chill of the room send goosebumps across your flesh. You feel the awful squirming of disease that has burdened you for so long. To turn the conversation towards these indignities would only derail your visit, as it has time and time again, and it has been impressed upon you, their time is valuable. There are so many patients and so few of them. With their intake completed, they leave you with a friendly smile, completely unaware of how little faith you have in them. As the patient, you have already been failed. Time stretches unbearably and uncountably long in that freezing room. Yet you wait patiently. After all, that is your job. To do otherwise would only be to the detriment of your care. You have thrown yourself at their mercy. The door clicks and the procession of professionals proceeds. The first is a bright-eyed student who immediately uses the wrong name. Gently, you correct them, and the visit continues. They conclude and leave. Next comes the exhausted resident, with a student in tow. The student's mistake is repeated, yet there is no attempt at correction. You ignore the look of empathy the student shoots at you, as if to say, I told them. You do not need or want their pity. It is clear the resident does not see you for what you are as they begin interrogating your medications, your choices, your lifestyle. They do all they can to pin your illness on a fault of your own. You are not heard. You are barely considered as they leave, clearly frustrated their visit took longer than expected. As if you hadn't already spent half your day here. As if you already hadn't lost half a day of wages, only to be demeaned and ignored. As if you want to be here any more than them. Finally, both return, their attending last to enter. You repeat answers again to what they consider key questions, interjecting when you can to remind them that you are sick and need help. It is clear they expected this defiance. The names of tests, diseases, medications are thrown over your head. They suspect this is because of your hormones, just as nearly every visit has in the past. They ignored your history, failed to recognize the years of treatment that has passed without issue, failed to consider or listen beyond their biases, failed to look beyond their chart at the person sitting in front of them, who is so clearly no longer resembles that rancidly compressed JPEG in the top left corner of the screen they think you cannot see. As if you couldn't see their note that has continued treating you as if you were the same person in that picture. You are sick. You shut down. You feel sick as they talk over you. You are sick of being sick. You are sick of being treated without the respect you deserve. You are sick of placing yourself in the hands of those who do not care to see you. You are sick of placating those who claim to know better, yet have failed in the most basic duty of their profession. You are sick of their empty niceties and their questions. You are sick of educating those whose job it is to know. You are sick. In the years of wisdom and experience, the attending finally notices you. Their tone shifts. They suggest a follow-up for further testing and offer a treatment now. Something to get you back on your feet, they say. You don't remember the rest of the visit as you are sent on your way with promises of a prescription sent and further investigation into something you do not want to know. The bright sun on your skin nearly burns after so long in the cold. You sit in your car alone, head in your hands. You will not be coming back. You steel yourself to begin the cycle anew. You are sick, and nobody cares.
This story emphasizes the impact that intentionality can have on the patient's lives.
The details of a name, of an accurate history, those simple things may not seem like much at first glance, but over time they can start to weigh heavily. How do you approach a situation like this?
I think the easiest method is prevention. Beginning the encounter tuned into the details of the patient's story will start you down the right path. However, for a patient like this who has had negative experiences and feels like no one cares about their health, how do you reach to them and let you know we do care? What are those intentional steps we can take as providers to make them feel cared for? All are thoughtful reflections to consider.
We've seen what happens when we take out intentionality. So let's move on to see the outcome when we take those intentional steps with a story from a fourth-year medical student during their third-year rotation.
Hey, thanks for checking out the Scrubbed In Narratives from the Front Lines podcast. If you're enjoying this episode, take a moment to follow or subscribe wherever you're listening, and help us grow by sharing it with a friend, colleague, or fellow student. You can also connect with us on all social media platforms or email us at pcmcourse@uthsc.edu with your thoughts, reflections, or questions. We'd love to hear your story too. Okay, now, let's get back to the front lines.
When I started on family medicine rotation, I joked that I had made it 4 months into M3 without having a man as a patient. I had started on OB-GYN and pediatrics and had not a single adult male patient. My joke rang true when my first male patient was a man, with a penis issue, of course. I started the clinical encounter as usual, and he was clear that the primary motivator for coming into the office that day was to seek a solution for his erectile dysfunction. After going through the review systems and making sure we weren't missing any medical drivers that could be contributing to this, I simply asked him what he thought might have caused this change in his libido. He told me all about the last 8 years, which included his wife of many years falling ill, watching her battle her illness, losing her, and finding his way back to some sense of normalcy. He shared some of his feelings about their sex life falling by the wayside as her health deteriorated. He shared how he had been feeling in the years since her passing. He shared all of the little things that he did to make it through the day, to take care of himself, to move forward. Very quickly, this visit became a lot more impactful than just a simple appointment to get Viagra. I'd spent most of the visit simply listening to his story and his concerns about various medical options. When he had finished speaking, I told him what I knew about treatment options and assured him that my attendee would have additional insights. And when my attendee came in and presented similar options, the patient stopped him. He took a moment to thank my attendee for being such a good doctor for him for the last decade, and he took a moment to thank me for listening and caring. One of the simplest things that we can do as medical students is taking the time to listen to our patients. It truly is the best medicine at times, and we are the person on the care team with the most time to do it. Taking the time to listen to patients, to explain things thoroughly, or to sit with their concerns is never time wasted.
I love that line. Taking the time to listen to patients is never time wasted.
For me, what stands out most from the story is how it shows that the work we do as a physician is a two-way relationship. Being intentional and listening to your patient's story doesn't just benefit the patient, it really helps the physicians too.
Exactly. I can think of so many moments in my own life where I've learned the most simply by listening into someone else's story. It makes me wonder, though, medicine never slows down. How do you make space to hear each patient's story when you're responsible for so many people?
That's a tough balance to find, and I think it will vary for everyone. The important thing to remember is that it isn't necessarily about the quantity of time spent, but the quality. You may only have a moment to spare, but sometimes we never realize the value of that moment. The act of slowing down to lean in and listen can mean the difference that saves a life.
I'm with you in that every moment is valuable, but saving a life might be a bit dramatic.
You think so? Then it's your turn to take a moment to listen. Here's a story from another fourth-year student from their third-year rotation who learned a lesson in what happens when you lapse in listening. During one of my first rotations of my M3 year, we were taking care of a 59-year-old gentleman with a diabetic foot wound who was well known to the residents on the service. This patient was non-compliant and a frequent flyer who frustrated the residents because of his apparent unwillingness to take care of themselves. Per the residents, This patient had the means to acquire and take his prescribed medications, but simply chose not to. I was assigned to follow this patient, and every morning he would dodge my questions when I would attempt to ask him about taking his medications, often by telling me stories of fish he had recently caught, informing me of health issues affecting his distant family members, or by complaining about the state of his bed sheets, wound dressing, and meal options. Our encounters often took much longer than those with my other patients, and I honestly began to dread going into his room each morning, wondering what kind of story I was going to have to sit through this time. Finally, the day came for this patient to discharge. It was a Friday, and I had the upcoming weekend off, so I was very excited to get this patient, as well as myself, out of the hospital as soon as possible. During our final encounter, the patient again danced around the idea of taking his diabetes medications more thoroughly. This time, his strategy was to talk about how his groin hurts. He said it had been going on for a while now, and that it tended to be worse in the morning and better after he got up and started moving. He suggested that maybe he is not walking enough. His legs are tired in the hospital bed. I laughed and agreed with him, saying it was a good thing he would be discharging today, so he can get up and start moving again. I then left the room as soon as I had a chance. No way am I examining this patient's groin. During rounds that morning, I did not mention his leg pain, chalking it up as the latest in a laundry list of daily grievances for this patient. The resident who saw him after me also said nothing. I presented my other patients, wrote my note, and then I left to enjoy my golden weekend. Upon my return on Monday, I saw the patient's name was still on our list. When I mentioned this to the resident, he informed me that we did in fact discharge the patient on Friday, but that he came back to the ER on Sunday evening complaining of groin pain and fever. Apparently, the patient's groin was swollen like a volleyball, erythematous, and exquisitely tender to light touch. Surgery was consulted, who obtained imaging that revealed a large groin abscess with sepsis. An abscess to septicemia is life-threatening in patients with uncontrolled diabetes. Thus, in diabetic patients complaining of pain, cellulitis must be ruled out immediately. Thankfully, this particular patient ended up getting the care he needed in time and was eventually discharged. However, in the days and weeks that followed, I had horrendous pangs of guilt in my stomach. The man could have died because I let my bias lull me to sleep. Overall, my experience with this patient served as a sharp reminder of the weight that a physician's actions, or non-actions in my case, carry. From that moment on, I began trying to listen to my patients in a more non-judgmental fashion, regardless of their background or whatever they have told me in previous encounters. If a patient complained to me about an issue, I owed it to them to at least check it out. In doing so, I have caught several conditions over the last year, including bed sores, mood disorders, and pneumonias that were all hiding under the surface of a patient's initial presentation. Medical training can be brutal. Our mistakes can have life-altering consequences. That being said, those same mistakes can also lead to changes that save countless lives moving forward.
All right, so maybe a moment could save a life.
I mean, what really stood out to me in this story is the student's reflection at the end, in that mistakes can have life-altering consequences, but also changes that save countless lives moving forward. Another important aspect of intentionality is being purposeful in the way you look at mistakes.
Making mistakes is part of the learning process, and making a process is actually another aspect of intentionality that is important to discuss. Let's hear from a future doctor in training about how they learned the need for a process, especially at the end of a long, tiring call shift. Deep into a 24-hour trauma call shift, after being beaten down with endless notes and scut work, the team was finally settling down and beginning to catch up on paperwork. My feet were aching from being on the go, my eyelids were beginning to droop, and I thought it might finally be time to breathe for a moment. Unfortunately, a patient on the med-surg floor upstairs had different ideas. My supervising resident was paged for this particular patient who had been stable on the floor for several days, as he was experiencing new onset chest pain and shortness of breath. With routine nonchalance, the resident ordered the standard workup: stat labs, chest x-ray, EKG, so on and so forth. I was asked to go evaluate the patient while the resident finished another task. In the rush of things, I read the handoff summary on the list while making my way upstairs. The patient was 9 days status post-neck exploration with carotid reconstruction and right chest tube placement secondary to gunshot wounds. I mentally prepared for the basics: airway, breathing, circulation, and the classic chest pain factors: heart attack, pneumothorax, rib fracture pain, even panic attacks. When I entered the room, things were already in motion in a smooth, rehearsed fashion. Nurses were collecting labs, the EKG was printing. Everything felt like it was going according to plan. I dutifully collected an interval history. The patient had sudden onset central chest pain for 15 minutes and had no other helpful information to give. In fact, he became agitated when I began asking more specifics. Last bowel movement, pain medication schedule, pain radiation. As any good medical student would, I exposed the patient's chest down to the xiphoid and listened to both heart and lung sounds. Normal rate and rhythm, clear to auscultation bilaterally. Diagnostic tests began returning and everything looked normal to me. No ST elevation, sinus tachycardia, no large pneumothorax, no midline shift. Tensions began to rise as his chest pain continued without any definitive cause. I used the "I'm just a med student" excuse when the nurses looked to me for answers, unsatisfied. It would be another 15 minutes before my resident arrived. The nurses ignored the plethora of diagnostic data and instead promptly pulled the blankets down further to expose a protuberant, rock-hard abdomen. Less than 5 minutes later, the patient had an NG tube which drained over a liter of bilious and gastric-appearing fluid from the stomach, much improving his pain. You see, when this patient was shot, the bullet entered his left neck. It also caused a vertebral body burst fracture, damaging his spinal cord and depriving him of any neurological input below his clavicles. In my haste and my reliance on the routine nature of chest pain workups, I failed to see an obvious differential. I failed to read and know my patients. And worst of all, I failed to perform a routine, thorough physical exam, which would have led me immediately to the root cause. This would have spared the patient time, pain, radiation exposure, money, and more. The lessons taught in principles of clinical medicine are taught for a reason. It can often be difficult to get underclassmen to buy into PCM when they are swamped with book memorization of basic science material. However, the ability to perform a proper history and physical exam and incorporate one's findings into critical diagnostic reasoning undeniably influence patient care more than any other lessons in the preclinical phase.
Have you ever been in a meeting or class where you just thought, this is not worth my time, only to find out the information from it was needed later on? The way this student reflected on the value of a course that many of their peers found tedious is a sign of intentionality in the learning process.
I've certainly been in those situations. I believe the most difficult part is seeing the future value of something when you're in the moment. By highlighting the importance of creating a process that incorporates learned preclinical skills, hopefully we will show that value.
A process doesn't have to be grand, but it does have to be detailed. I hope that is what we have been able to impress upon everyone tuning in today. Intentionality is about paying attention to the details.
You've been listening to Scrubbed In, Narratives from the Front Lines, a UT Health Science Center, College of Medicine production in collaboration with the Teaching and Learning Center. If any of today's stories moved you, challenged you, or inspired you to see medicine through a new lens, we want to hear from you. Connect with us on all social media platforms at UT College of Medicine, or email us at pcmcourse@uthsc.edu. And for info about the Principles of Clinical Medicine course and or other educational initiatives from the UT College of Medicine, visit uthsc.edu. Until next time, stay curious, stay compassionate, keep learning, and keep scrubbing in.